Thank you so much all for being here. Good afternoon, everyone. My name is Shaib Jama, aka Jet, and I am the Community Health and Wellness Coordinator at ETSS. Welcome to today's training on addressing emergency response, disaster preparedness, and culturally tailored behavioral health response services for the Bhutanese community. This training is the third training in the series, and we have 3 more trainings left after this, and I hope to see you there for those ones as well. So let's go to the next slide. So this is the, behavioral health disaster planning and response for the Bhutanese community. Okay, so this was a 2024 study. It was titled Culturally and Linguistically Appropriate Emergency Preparedness and Crisis Response for Ohio's Resettled Communities. Here are the following authors, and to access the report, you can scan your this QR code, or there's a link right there. But I think even if you just search the title of the report, you should be able to find it on Gov Delivery. There's multiple ways that you can access this report, but this presentation will be basically breaking down. The report was very complex. We had all of the 5 communities. The first training, we focused on all of them. And then the following trainings are for each specific community. For July 1st, we had the Afghan one. Today, we have the Bhutanese Nepali one, or the Bhutanese community presentation. So if you want to look at all of them, please scan the QR code and you can access the report there. So I just wanted to go over some group agreements before we officially get started. So AI note takers are not allowed in state meetings or trainings. This session is being recorded and will be made publicly available. And then you are welcome to use the chat and Q&A feature to ask any questions and to communicate with me and as well other presenters or other organizers. So I just wanted to acknowledge a few people. So first I wanted to acknowledge Ohio Moss. ETSS obtained this grant through Ohio Moss, and we were able to conduct the study last year in 2024. And also for this current grant, we received funding from Ohio Moss. And so we wanted to thank Ohio Moss and specifically Liz Poprocki, which is the Behavioral Health Treatment Coordinator, and Dr. Adhikari, which is the Administrator for Disparity Research Lead, QPR. I also want to acknowledge Suzanne Schaefer and Amy Harkar, they're both directors at ETSS, for their dedication and project leadership. Suzanne worked closely with us last year on the grant, and Amy is working very closely with us this year. So I wanted to thank them both. And I also wanted to thank the entire ETSS Community Health and Wellness team. As you're going to see shortly, we put in a lot of work into this project, and we came together, made social media posts, built kits, everything. So I just wanted to thank the Community Health and Wellness team and ETSS as large. And then I also wanted to thank Israel. Israel was our coordinator for the Ethiopian community at that time. And I just wanted to thank her because she wasn't officially working with us back then, but we were able to get her on just to do the social media aspect, and she did amazing. So thank you, Israel. I also wanted to acknowledge the community-based organizations and their respective leaders. So for the Bhutanese community, we worked with Vedic Welfare Society, and they are here today. So thank you so much for your hard work last year, and thank you for being here today. And then for the contact information is Mr. Durga, and his email is right there in the slide. Next. Okay, so the webinar outline is this. So we're going to start with, after I show you the questions, which should be the next slide. We'll start with the Bhutanese community presentation. Then I'll cover a little bit of gaps in the importance of these trainings. Then we'll cover some of the quantitative and qualitative aspects of this research. Then we'll go over the information dissemination, emergency kits, and community contacts. And then we'll do a brief resource walkthrough and conclusion. So these are the questions that the community will be answering. Each community was asked these 6 questions, and they put together an amazing presentation. And I will pass it on now to Chanda Subidi and Kamal Subidi to go over their presentation. Thank you so much.
Good afternoon. I'm Kamal Subedi, representing Vedic Welfare Society of the ex-president, and currently I am just a volunteer there. And typically, where are we from? Means already said that we are Bhutanese. We came from Bhutan. So Bhutan is a small country between two giant countries like India and China. It's sandwiched between the two countries. It's a small country, and it is quite indigenous. There are 3 leading ethnic groups: the ruling group, and we, the Nepali-speaking Bhutanese, called as Lochampas, and people on the east side of the country called Nalons. So those are the 3 main groups. Can you please help me with the next slide? So why are we here in United States? It's a question that is asked all the time, and we had been answering. So there were some political and ethnic problems that happened in our country till it was since 1980s. Then it went over, and during early 1990s, the conflict escalated. Then it is both political and ethnic. So it is kind of ethnic cleansing, but it was not only ethnic demand at the end. We were trying to ask some political changes in the ruling system also. So that crisis escalated, and it has a lot to do with human rights. There were human rights violations, and with that, we were forced out of the country, and we were in Nepal. We went to India, and we stayed in Nepal, and we were there as refugees for at least 15 years, and went up to 20, 25 years. I was a refugee for a good 17 years in the camps of Nepal. So when there was no long-term solution to the Bhutanese refugee crisis, the Nepalese system, the Nepal government, and UN, along with other countries, they started resettling all these people to different countries. And of the 7 or 8 countries that we were resettled, USA is one of those. So we are here, as we said, we are here since 2008. So the first batch of refugees, they came here in Columbus or all the major cities where we were resettled. They started coming up since 2008. And right now, in and around Columbus, we don't have exact data, and the census data is quite not clear, because some people, they identify ourselves as Nepalese also, as Bhutanese also, and some even identified themselves as Asians in the census. So our data from the Census Bureau is not coming so clear, but we expect at least 40,000 people in Columbus Metroplex. So it should be more than that. We say 40 to 45,000. So many people are resettled here right now. Not only resettled, they moved from other cities also. And we have a very strong cultural values. We respect our families, and you may be surprised that there are many families with 3 generations, and some families with 4 generations of people living together. Even today, if you come to Reynoldsburg, Black Lake, Pickerington, where our community is heavily located, you will see at least 3 to 4 generations of people living together. So we believe in cultural family values. We celebrate festivals like Dasai, Tihar, Losar. We eat Nepali food. We dance. We have our own music, and we are very spiritual, strong religiously. So we are Hindus, Buddhists, and Christians, and those are the leading religious group in our community. So we have been giving back to the community for a while. So since we came back, we had been working. So there are a lot of people working in health sector, IT sector, and education sector, and in business. Most of the people, many people, they are going into business right now, and we have a very healthy number of people that doing business right now. We volunteer at schools, all social organization, and we do small blood donations also. We are almost an integral part of this community now. So we do all integral things that a normal American had done all these years. And we have established churches, community organizations in in the community. And we have local representations also now. People have started running for office. We have already have one elected official in Ralph, and there are a few coming this election. And when it comes to disaster, we have we have like every community when we live here, we face disasters. So there are many disaster that happen, and one of the most common is house fire. I don't know how people are still not totally aware or not knowing to use the system here. So we have house fires, and we have uh, flooding also, basement flooding and local flooding and storm flooding. And on top of that, a growing concern that is in our community right now is mental health, though it may not be classified as a full-fledged disaster, but we have mental health issues. And following up with mental health issues, we have an alarming rate of suicide in our community, which is much higher than the national average. So that is community-wise, if we take the percentage of community suicide rate, it is much higher than the national rate of USA. So that is alarming. And with mental health, there is growing addiction also, and drug abuse, substance abuse in younger generation especially. The younger generation is getting into drugs and substance abuse. And to some insignificant amount, we have gun violence also happening now. It is increasing because gun was not a thing when we came to USA. Now it has got into our community and misused also. So, and we have domestic violence also. Domestic violence, there are a lot of cases coming from domestic violence side also. And means obviously COVID-19 was very strong to us. So we have barriers, language barriers. Still, we have older communities who are even in 40s, and means we have been here almost for 15 years and in an average, but we still have communities starting at the age of 40 who are still struggling with language. So communication is a bigger concern, and since communication is a concern, so we have lack of information and awareness, because once the communication is some are not informed and made aware because of lack of education, or because of lack of having resources in our own language. On top of that, all people are not, those who have a little bit of communication, those who know English also, they are not having the information. Might be they are not interested, or they are not reaching to those resources where information is available. So we have very strong community support. We believe in standing together as a community. So when something happens, we always are together as a community. We try to help each other. We try, even if there is a fire disaster in one of the houses, then next day onwards, we have a lot of donation, food, money. We try to make the transition process to that family as soon as possible. So on top of the local resources or resources from Red Cross and all other systematic help, we have very strong community help, and we try to stand up from all the disaster by helping each other from the community. So how can things be made better for us? So the first thing is we want means we want we want every providers to know the Bhutanese problem. So so that no problem means how to handle, how to get into a Bhutanese culture, so that if there are any issues, any problem, they can be addressed in a culturally appropriate manner. And we are first generation of immigrants here. We have a new generation coming up. Many kids are born here. So for us, the system is uh, not so familiar. We have to be familiarized with the system. And the other thing is we have a huge generation gap between the new generation and the old generation. So that not only in terms of language, not only in terms of age, we grew up, the older generation who grew up back in Nepal and Bhutan, they were brought up with different values, different system. And we have new generation who went to school here. We have different belief system, we have different values. So the difference between the old generation who got old schooling back home and the new schooling out here, so that is growing. So every time, whenever there are chances, when you try to address the community, I think that has to be considered, and we have to have representation from our community in all non-profits and all resettlement organizations, and we should be respected, and that's all for for all, and so I think that's all briefly because time was coming behind me, so I might have rushed through the slide. So if we have any specific questions that can be answered from a community perspective in addressing the disaster crisis, I'll try my best to answer it, and we have members from the community who might be adding to what I will be saying. Yes, sir.
I I have done that in the national rate. I was wondering if there is difference among the different demography. Like, is it higher among the youth? Or because you mentioned even 4 generations in the same family.
Yeah.
So I think more the balance among the elderly, the adults, the youth is dropping.
Uh, uh, I don't mean I was trying to recall some bit. I don't have exact data, but the thing is, it's more of the generation that didn't go to school here in USA. So those who went to school here, I think they might have a fairly educated, got adjusted with the American system, or they know where to get help when they have issues like that. They know exactly how to address mental issue if they get one. Or so might be mostly suicide is from generation who went to school, or elderly people who felt really hopeless after coming here, or people in their 50s, 60s who don't have enough skills to make their existence here, and their kids were not much supportive because we have that generation gap problem. So I think it will be fair enough to say that most of the people who committed suicide are from that generation who went to school back home, or who never went to school at all. The question was about where means is the suicide rate more prominent with younger, older, or which generation of Nepali people living here in USA? So I was trying to say that generation which didn't go to school here in USA. So with that, I'll take leave from here. So if there are any questions, you can email me, or anyone from Vedic Welfare Society. We'll try our best to answer it. And question came up, so
Okay, so somebody online asked, I worked with the Bhutanese community of Central Ohio, and we have a little trouble keeping people from this community engaged. Is there a good way to be more effective when it comes to outreach for your community and how to keep them engaged?
uh, uh, even when we try to work in the community, keeping people engaged, it is an issue. So we don't have a one button or one stop solution for getting people engaged. I think our approach when we work at Vedic Welfare Society, our approach is if we expect people to come to us and get engaged, and if that doesn't work, we go to them. So that is one approach that we follow and we try to implement. If we expect people to come to our Vedic Welfare Society Center and get engaged with us and get interacted or get something done. And if that doesn't work, we are people from the community. We just drive our car, go to their house and try to get involved that way and try to bring them back to the center next time. Thank you.
Okay, thank you so much for that, Mr. Kamal, and thank you so much for that amazing presentation, Vedic Welfare Society. Okay, so now can we pull back up the slides again, and then we can move forward with the rest of the presentation. So Mr. Kamal did a good job at covering all the gaps already, but there's a few that I just wanted to emphasize and highlight. He already spoke about how the community faces a high burden of mental health issues, and you asked some amazing questions on that. And then I also wanted to highlight cultural values and stigma around mental health, discourage people from seeking help during times of crisis. And then he talked about the multi-generational households, which offer both strengths, but also when it comes to challenges, you have to care for more people, you have to look out for more people, which is a challenge. So, and then Bhutanese voices are underrepresented in local emergency planning and disaster response efforts. So just maybe including them, I really like what Mr. Kamal said of, if they don't come to you, go to them. That's very important, and we try to do that here at ETSS too, where we go to where we know the community members are going to be. So I was glad to hear that. I wanted to quickly cover the importance of these current webinar series. So the lack of guidance on culturally appropriate approaches is not a lot. So that's why we wanted to host these trainings to increase to increase the knowledge of appropriate, culturally appropriate approaches. And then we wanted to talk about cultural misunderstandings can weaken service delivery. So I know I went to a training and they mentioned how somebody from the Bhutanese Nepali community only wanted hot water, and they were asking, why do you want hot water? So knowing that more about the community helps you to better understand them. And then this webinar will disseminate the findings from the previous study, and then building culturally competence is essential to bridge the gap in healthcare. And then for the next slide, this is just the dates for all of the trainings. We already did the May 23rd, July 1st, and today is the July 8th one for the Bhutanese community. Stay on the lookout for the Eventbrite link for the Somali community for July 17th, the Ethiopian Eritrean community on July 24th, and then on August 8th, the Congolese community. So that is everything that I wanted to go over. I will now be passing it on to Dr. Saruna Gamiri to go over the quantitative results. Take it away, Dr. Saruna.
Okay, so thank you again, Jet. Good afternoon, everybody. My name is Saruna Ghimire, and I am Associate Professor at Miami University here in Ohio. I had the privilege of being one of the team member for the 2024 study that we did and share with you at the beginning of this webinar. And I'm so honored to be part of this webinar series where I could share some of the findings we found from that study. We learned a lot working with these communities, and I'm so honored to share that info with you all today. Before I talk about what we found, I just wanted to give you a quick overview of the methodology we did. And it was a survey with 266 adults, 18 and older, living in Central Ohio. We included participants from 5 different communities that included Afghan, Bhutanese, Congolese, Ethiopian Eritrean, and Somali. And as Jet mentioned, like we are doing a series of webinar focusing on one community at a time. And today we are focusing on the Bhutanese community. Of the 266 total participant, we had 51 participant from the Bhutanese community. Recruitment was led by ETSS in collaboration with local community-based organization. And specifically for the Bhutanese community, we got so much support and help, and we would not have been able to do it without their support. So shout out to our partner, Vedic Welfare Society, who helped us not just with the last year study, but also with the current webinar series. So our survey was available both online via Qualtrics and also on paper if participants prefer that way better. To ensure it was accessible to different communities, it was available in different languages, particularly for the Bhutanese community. Our survey was available in Nepali language, which is the most common language spoken by um, people from the Bhutanese community in Ohio. So next I will be sharing with you a very brief overview of participant characteristic just to understand who are these people who participated in our survey. First, I wanted to just clarify that for most of the result that I will be sharing with you, we have broken it into two ways. On my left, in the blue, you will see the overall finding that represents all 5 communities together. On my right with the green, you see the finding specific for the Bhutanese community. And I believe this is a way to understand both the overall pattern and also what is unique about the Bhutanese group compared to all 5 communities together. Uh, so speaking of age and gender distribution, for the Bhutanese community, most participants were between the ages of 26 and 45 years old. And this age distribution was very similar when we compared with the overall sample. In terms of gender, among the Bhutanese participant, men made slightly majority with 53%, while women accounted for a slightly less than half. This contrasts with our overall sample, where the majority was represented by women. This slide will help us to understand how long participants have lived in the US and how comfortable they are with English language. We did hear language come up frequently as we were hearing the presentation from Vedic Welfare Society, and here is a breakdown based on that. So the Bhutanese, among the Bhutanese community in our sample, they appear to be relatively well established in the US and have lived here for more than 5 years. Only about 15% had arrived recently within the past year. And in terms of English proficiency, the Bhutanese participant reported higher rates of being able to read, write, and speak in English, with the majority of them able to do all three. However, I also wanted to bring your attention to note that still about 1 in 10 reported no English proficiency at all. And as Mr. Kamal pointed out, there are differences by demographic, older versus younger, maybe male versus female. So these findings suggest that while the Bhutanese community is generally well integrated linguistically, and have had time to adjust to life in the US, there are still some demographic that still face language related barriers, especially when it comes to understanding information or accessing emergency services. In this slide, we look at formal education level. And here we see that in terms of formal education, the Bhutanese group again stood out, and more than half, 56% to be precise, had completed college education, compared to only 32% in the overall sample. Uh, Disability was another important factor that we examined because households with members with disability may encounter additional challenges during emergencies. So we asked participants about individual disability and caregiving responsibility for a family member with disability. Among the Bhutanese participant, more than a quarter reported having a disability themselves, and roughly 37% said that they have a household member with a disability that they are responsible for caring. Disability experiences by our Bhutanese participant are higher than those that we see in the overall sample. So next I move to the section on disaster experiences and uh, whether our Bhutanese participant had experiences any disaster, their level of preparedness, and whether they have any management plan in place. The first thing we asked them is whether they had experienced a disaster while living in the US. First, across all 5 communities combined, about 20% said yes, they had experienced a disaster in the US. However, among the Bhutanese participant, that number was much higher, where more than half said that they had experienced a disaster. The most common type of emergencies experienced by the Bhutanese respondent were pandemics, home fire. Again, Mr. Kamal already pointed that out, and we also found in our survey, and also power outage. There were also other type of emergencies participant experienced, as you can see in the figure. Next, we asked participants what they know about disaster preparedness and what steps they have taken, if any. Only about 10% of the Bhutanese participants said that they were not familiar at all, compared to 23% in the overall sample. About one-third of the Bhutanese participants said that they were very familiar with preparedness topic, and this is higher than the overall group, where only 21% reported being very familiar. So these together suggest that compared to the overall group, the Bhutanese participant had higher awareness level for emergency preparedness. Among those who did report some knowledge, the most common things people said were making their homes safer, gathering or updating emergency supplies, signaling for signing up for emergency alert and warning, and making emergency plan. We also asked participants two important questions. How likely do you think that a disaster will affect your area? And if it did, how confident are you in your ability to respond? Among Bhutanese participants, nearly 60% believed a disaster was either unlikely or they said that they did not know if it was likely to happen. Only 40% believed that a disaster was likely to occur. When it comes to confidence, only 40% felt extremely confident in their ability to respond to a disaster. The majority felt only somewhat confident or not confident at all. However, when we compare these findings to the overall group, Bhutanese participants still showed slightly higher level of confidence in their preparedness. So as we note that among Bhutanese participants, while awareness is relatively high, many participants still are uncertain about the actual risk and they have lack of full confidence in their ability to act. This points to an important area for improvement for us as a service provider, where where preparedness program focusing on building practical skills like drills and hands-on training may help our participant and these communities to feel more confident and ready to take action in time of real emergencies. We also asked participants whether they currently have a disaster or emergency response plan in place. And among the Bhutanese participants, about 61% said that they did have a plan. This is much higher than the overall sample, where only about 40% reported having a plan in place. For those Bhutanese household that had taken steps to prepare, the most common action plans included signing up for emergency alert and warnings, safeguarding important documents, property insurance, saving money for emergencies, and getting involved in community preparedness activities. These are all really encouraging initial steps that the community has taken. However, I also wanted to draw your attention that it is still important to recognize that about 40% of the respondent still, or if you translate it to maybe household, still did not have a plan in place. And this highlights the need to continue supporting these families by providing accessible, culturally relevant, and easy to use tools for emergency preparedness. Now let's look at some of the barriers and challenges participants faced when trying to access emergency preparedness resources. Among Bhutanese participants, only 35% said that they had no difficulty in accessing emergency preparedness resources. About 30% reported having difficulty accessing these resources, and the remaining, which is about 37%, said they had never accessed these resources at all. So this means that nearly two-thirds of the Bhutanese participant either faced barriers or they had no engagement with the preparedness resources. And these findings point to a need to both raise awareness about available resources and address any barrier people have to access them. And we will talk about some of these barriers in next few slides. Next, we asked participants if they knew how to get help during an emergencies, and about 71% of the Bhutanese respondent said yes, they did know how to get help. This is much higher than the overall sample, which is a very positive sign. It suggests that many Bhutanese community members are connected to the formal emergency services that we have around. However, nearly 1 in 3 still did not know how to get help. And again, this provides an opportunity for service provider like us uh, to bring them on board, and there is a way we can do better marketing of available resources for them to access. Next, we asked participants about specific reason why they may have had difficulty accessing emergency preparedness services. Among the Bhutanese participants, more than half said language as a key barrier. Again, what Mr. Kamal said earlier, our survey participant reinforced the same idea that language was a key barrier. And this was not just about the Bhutanese community, but it was the most significant barriers for the overall group that included all 5 communities. Other barriers the Bhutanese community encounter included difficulty due to sexual orientation, religious practices, cultural norms, and race. We also asked participants whether they felt emergency preparedness materials were culturally appropriate. For the Bhutanese community, most said that the material were either very appropriate or somehow appropriate. Still, a significant number, about 1/5 to be precise, said the material did not feel culturally appropriate. And again, this points to maybe we are talking about a particular subset or demographic that may have felt that way. So, but still, compared to other communities, the Bhutanese participants were less likely to feel that the materials were completely off base. We also asked participants whether they had participated in any emergency preparedness training in the recent years. And for most of the Bhutanese participants, the answer was no. which was also similar when we compared them with the overall responses with all the communities combined. Now, exploring reason why people did not participate in the training, and it was not due to a lack of interest. The main reason that the Bhutanese participant pointed was conflicting priorities or time constraint, while others simply did not know that this training existed. Lack of culturally competent staff was another important barrier identified by our participant. So there is a message for us to make existing resources more accessible, and we need to focus on better marketing and promoting available trainings, because a lot of these people do not even know that these resources exist in the first place. We also have opportunity to make them more accessible by hosting them in trusted community spaces and ensuring that they are culturally appropriate and welcoming. Next, we looked at how often emergency preparedness is actually discussed in the community itself and what approaches work best when it is. Among the Bhutanese participant, about 60% said that their community ever talks about preparedness. While this means that the topic is not yet a regular part of the conversation, but we were still happy, and it was encouraging to see that a substantial 40% reported active discussion, which we believe is a great starting point. This shows there is a growing awareness and interest to make emergency preparedness part of community dialogue, but more can be done to make these as a regular topic of conversation. Regarding the most effective ways to share information, participants identified community meetings, gathering at religious or worship places, social media, and partnership with trusted community organizations as some of the effective strategies. Again, this all tells us a consistent message. Work with the existing community structure. Just like Mr. Kamal pointed out, if they do not come to you, we need to go to them. So using gatherings that people already attend, like temple and other community events, using messenger that they already trust, and this is how we can really start to shift awareness and action in a way that feels comfortable and familiar. Next, we asked participants how emergency preparedness could be improved, and their suggestions were both practical and thoughtful. The most preferred ways to receive information were text message and phone calls, followed by emails. Participants also found tools like flyers, digital resources or websites, lesson plan, and activity books to be helpful. To improve preparedness overall, they emphasized a few key strategies: hiring multilingual staff who are from and trusted by the community, offering trainings in multiple languages, because we have repeatedly heard languages are one of the key barriers in these communities, and creating materials by the community for the community in local languages. These ideas make one thing clear and simple for us. Preparedness efforts are most effective when they are rooted in trust, built with cultural aspect, and delivered in the languages people live in. With this, I wrap up the quantitative survey and hand it over to Jed. Thank you so much.
So welcome back, everyone. And thank you so much for being here. I hope you all enjoyed your break. I will be passing it on to Isha to go over the qualitative portion of this grant. So take it away, Isha.
Again, welcome back, everyone. Thank you for joining us in today's webinar. Good afternoon. I'm Isha Karmacharya, doctorate graduate from Miami University of Ohio. I was also involved in the 2024 study. I had an excellent opportunity to work for ETSS for this project, majorly contributing the qualitative part. So I'll shift gear to what we learned from the youths through a focus group discussion, especially focusing on the voices of Bhutanese youth. And this discussion was very insightful. Probably will repeat what Mr. Kamal Subaidi and Dr. Kimire have been talking about. So you'll hear more from this qualitative study. So we spoke with 10 youths between the ages of 18 and 25 with representation from 5 refugee communities in our study. Here I'll be focusing, as I said, the voices from Bhutanese youths. So these youths were recruited through the ETSS Youth Advisory Panel and were all fluent in English. The session lasted about an hour and was guided by trained facilitators. So we focused in 4 areas, which were public health concerns, awareness of resources, barriers to challenges in preparedness, and community recommendations. So there were several important themes that emerged from this focus group discussion. First theme was on public health emergencies and crisis concerns. Second was awareness of resources of emergency preparedness. Third was about significant barriers on challenges for emergency preparedness. And fourth, youth shared their powerful recommendations for action to improve community preparedness. Youth participants also highlighted several critical public health challenges within their communities. These included substance abuse, suicide, gun violence, social isolation, and Bhutanese youth especially highlighted drug abuse and suicide in Bhutanese community, like Mr. Kamal Subaidi mentioned earlier. One youth explained, saying, I think drug abuse is probably one of the biggest emergencies that I have seen in my community, especially among kids around my age, high school kids, and even like middle school kids. I wanted to add that I think for the Bhutanese community, suicide is also another huge issue that we have seen recently. So youth share that these issues are often unspoken or normalized and not treated as urgent concerns, which delays prevention and healing. Participant also told us that when emergency happened, their first go-to resources are phones, Google, social media platforms like Facebook. They also emphasize that temples, churches, and other faith-based institutions are trusted community hubs and serve as informal gathering places and coordination point during crisis. For example, participants shared, if anything were to happen, like a big crisis, let's say a tornado or a shooting, everyone would convene at religious sites to figure out the course of action. They also acknowledge that some emergency resources exist, but say these services are often poorly publicized and difficult to access, especially for elders or non-English speakers. One participant put it clearly, there are definitely resources out there somewhere, but the issue is that finding about them is so difficult because there is no marketing for them. Participants also mentioned that emergency preparedness is rarely promoted by community leaders. This shows that there is a disconnection between service availability and accessibility among the community members. Youth identified language barriers as one of the biggest obstacles to preparedness. They shared that during COVID-19, many older adults in the Bhutanese community could not understand health messaging and even now don't know how to call 911 or follow safety alerts. A youth explained the older generation probably can't even call 911 properly because they don't speak English. Another youth gave an example during COVID crisis, saying it caused widespread confusion due to those language barriers when there was COVID, when they indicating healthcare professionals and social workers were trying to explain things, community members had a really difficult time grasping the information. So therefore, participants emphasized the urgent need for translated emergency materials and multilingual response system to help bridge this divide. Youth also reflected on how social media and outside influences have changed their communities. They shared concerns that communities are becoming more individualistic and disconnected, especially among youths exposed to harmful online contents. For example, one participant said, "I feel like a lot of it has to do with social media. People see everything online and try to be like that, losing their true selves. I have seen friends becoming more violent, influenced by what they see, even though they were not like that when they were younger." Another youth mentioned about the shift from collective community support to individualism, saying, "We went from being a community that always helped each other to grow and persevere, to becoming a lot more selfish." Therefore, while external sources like social media were reported as a source of awareness, they were also seen as contributors to disconnection and risk, leading people in their communities to adopt values that conflict with their norms. Another important theme was the normalization of trauma, especially from violence and displacement as a barrier of emergency preparedness. Youth shared that their communities often react to crisis with silence or short-term responses rather than long-term prevention or healing. For example, youth said, "People don't question why it might have happened, and they are so used to going through trauma because of the background they come from. They don't even think of it as trauma." Another youth explained a lack of deeper conversation, saying, "I feel like a lot of people, after someone died, I don't think they enough talk about like, oh, that person died. I wonder what could it have caused it." They start rumors and stuffs about like, oh, what their theories are about how they happen, but they don't question why it might have happened and stuff like that. So youth noted that people often don't even recognize their experiences as trauma because hardship have been so constant and they are so used to going through trauma. And this mindset definitely prevents communities from seeking help. Youth emphasize the stigma surrounding mental health. They explain the mental health is often seen as a taboo subject, especially among older adults. There's a strong fear of judgment, and this shows how stigma can keep people from accessing the very care that could help them. Now talking about the recommendations youth provided, they expressed a strong desire to be seen as active contributors, not just recipients of support. They even mentioned themselves as gatekeepers, explaining they can be medium to reach older adults in their home and community. They recommended involving young people in emergency planning and leadership roles, especially through school or community-based organizations. Participants even suggested youth should be seen as a community assets and part of solution. But they emphasize starting with informal relationship building events such as cultural games, celebration, or shared meals as a way to build trust prior to involving them in volunteering and leadership roles. Youth also emphasize the importance of clear, culturally relevant communications. They suggested using trusted messenger to deliver emergency information, and such as like community elders and spiritual leaders, or creating promotional videos with familiar faces, someone from their community whom they know or can relate to. Like a participant mentioned, from my community, the person presenting the information in the video needs to be someone from within our community. It's important that the video features someone familiar and trusted by the audience. Or additionally, instead of solely relying on YouTube, the video should be shared across Monday or Monday pages. The older generation places a great deal of trust in spiritual leaders, so having their endorsement or involvement would make the messages more impactful. So participants also suggest adding multilingual translators to 911 service to help bridge urgent language gaps. Finally, youth stress the need to build on existing cultural and faith-based networks. Temples and other religious sites already serve as trusted spaces and should be recognized as key partners during crisis rather than replacing these traditional systems. Youth recommended that public health and emergency organizations should work with them. Participants also mentioned that the biggest type of interventions we usually have stem from religion. So also participants emphasize community programs and helping each other to become aware and learn from each other. So therefore, the takeaway here is clear. Social support and culturally grounded engagement is essential for emergency preparedness. So all these voices are kind of similar what we heard from quantitative study findings and what Mr. Kamal Suvedi mentioned earlier. So youths also are voicing up different recommendations, different challenges they are having and the community members are having. So this is all from my end. Now I pass it to Jet to continue the presentation. Thank you.
Thank you so much for that, Isha. That was very informative. So now we will go on to the social media aspect, the information dissemination, emergency kits, and then also just some best practices, some resources, and then we'll wrap up the presentation for today. So let's go to the next slide. So getting critical information on time can make all the difference, especially during emergencies and crises. Our community health and wellness team led extensive information dissemination efforts to ensure communities had access to life-saving knowledge. These efforts were carefully documented in the Apricot under the weekly tally form. That's why you see Apricot weekly tally on the side of this table. In total, from May to August 2024, we had 237 direct contacts and distributed over 30,000 educational materials. But right now, what you're seeing is just the information dissemination for the Bhutanese community. So our community health navigator for the Bhutanese community was Durga. So I wanted to give a shout out to Durga. Thank you so much for all the hard work, Durga, that you put in to all of these social media posts that we will be sharing soon. And thank you for also getting these important information to your community. As you can see, Durga had 140 total contacts and distributed 7,515 materials. The difference between contacts and materials distributed is materials distributed just means you sent like a flyer or a website or an informational sheet to the client and there's no follow-up. Whereas a contact, there is a follow-up. So maybe you sent a flyer to the client and they say, hey, like, tell me more about this flyer, right? And you have a conversation with that client, that is considered a contact. And for the weekly tally, they're usually under 15 minutes. And if they're more than 15 minutes, we track it on another form. So now I'll be showing some of the social media posts that Durga made for her community. So these, originally we had a goal of producing 6 videos and 20 posts in total. But after the grant, we had, I think, let me see, it's on here. We had 8 videos and 21 posts. This is just an example that Durga made for the Bhutanese community. And then if you could go to the next slide, we wanted to play one of the videos that Durga made for her community. Basically, the way that our community health navigators did this was they went out to their communities, they looked at things that their communities were already struggling with. So whether it's fire or something else, and then they went ahead and created a culturally appropriate post that matched the nuance for the community. And they also translated into multiple languages. We translated it for the Bhutanese community. They speak Nepali, so we translated it into Nepali. And then in total, when it came to the reach, I think you're going to see that in the next slide. But let's play the first video, and
Heat,
I'll come back soon.
heat warning. Be prepared for extreme heat. Older adult, children, sick or overweight individuals are at higher risk. Never leave a child, adult, or animal alone inside a vehicle on a hot day. गर्मीको सजगता अत्याधिक गर्मीको लागि तयार हुनुहोस्। वृद्ध, वृद्धा, बालबालिका, बिरामी वा अधिक तौल भएका व्यक्तिहरू बढी जोखिममा हुन्छन्। न्यानो दिनमा अथवा गरम दिनमा गाडीभित्र बालबच्चा, वयस्क वा जनावरलाई एक्लै नछोड्नुहोस्। थप जानकारीको लागि तलको लिङ्क पछ्याउनुहोस्।
Okay, so as you can see that we Durga put a lot of work into this. You can see that the video had images, it had little words, and it also was translated in Nepali. Some of the we trusted the community navigator. Some of them didn't do videos in their language, and they just did the translations, and some of them did. And we left it up to the community health navigator. So now I will just briefly, if you can go to the next slide. So now I'll just briefly go over the social media metrics. So these are, this is from our advancement team. So a total of 68 posts were shared across ETSS social media platforms. The content reached 3,669 people, generated 1,186 impressions, and received 69 direct engagements. As you can see, Facebook had the widest reach, LinkedIn generated the most impressions, and Instagram had the highest engagement rates. Beyond the numbers, we built connection, trust, and accessibility across communities by relying on our diverse team and being culturally and linguistically appropriate. So this is just an image of the kits that we built. So we call them emergency kits. We built a total of 250 kits, and we gave each community 50 kits. As you can see, here's what some of the items that were on the kit. There's some just instant cold pack. There's an emergency radio. There's a carbon monoxide and a smoke detector. And then there's just a bunch of other supplies. We had some mental health resources as well from Adam H. and there. We had some COVID tests. We try to make it as the kits as wide as possible to cover as much emergencies, whatever they might be. There's a fire blanket, an emergency blanket, and we gave 50 to each community and asked them to distribute it how they felt it was best. Some of them hosted an event to distribute it. Some of them went to people's houses. We trusted with them with how they distributed these kits. And for the kits, we partnered with JPS Printing. So I just want to go ahead and just, next slide, please. So for the collaborative platform, you can see that in total, we had 81 community contacts from all of the 5 communities. For the Bhutanese community, we had 15 contacts. And then the main contact for that is Durga Timsina. And we shared his contact information earlier. So basically how this works is if you have any emergencies within the Bhutanese community, or you just want to talk to somebody from the community, my contact is there. I am the main contact person. Reach out to me and then just tell me, hey, I want to either talk to the Bhutanese community or Somali community, and I'll try to go pass your information or your question on to the leaders, or if you want to set up a meeting with everybody that was on these lists, you can. This list, basically, when I was asking the leaders to prepare it, I said, if anybody, like, let's say an emergency happened within your community and you know somebody that wants to respond, please list them on there, because we've had times where maybe there's a a crisis or emergency within a specific community and we didn't know who to reach out to, who was willing to help. And hopefully everybody on these contacts are willing to help. Just reach out to me and I'll forward your contact and information to the respective community. So now I just wanted to talk about some just best practices, some recommendations. So first is to translate emergency materials. And then number two is to engage trusted community leaders, such as leaders from the Vedic Welfare Society, BCCO. There's multiple organizations in the Bhutanese community. So just getting in contact with them and engaging them. Culturally tailored preparedness programs. So basically just having these culturally appropriate. So the term that we like to use here at ETSS is CLASS, which stands for culturally and linguistically appropriate services. So just making sure that anything you do is culturally tailored to the specific community. So for the Bhutanese community, make sure that it's translated in Nepali, make sure you have some youth involved and some members of the Bhutanese community involved as well. And then to expand peer-to-peer training models. So getting the people here today from Vedic Welfare Society, training them, and then having them go out to train their community because they will understand the nuances, they will understand how to approach certain things because a lot of things are stigmatized in the communities that we looked at for this research. And it's very important how you approach certain topics because it might shut somebody down. They might not want to listen to you if you don't approach it correctly. So that's why it's important to actually have somebody from the community connect and do this peer-to-peer support. And then just integrate suicide prevention strategies. So I know there's the QPR trainings. There's a bunch of trainings out there. So just looking at these strategies and then going over it with the community. Leverage community hubs such as community centers, temples, and I think they also shared that some of the community is Christian. So if you wanted to reach the Christian community members, maybe go into churches as well. And then include Bhutanese representatives in local emergency planning committees. And then last but not least, provide transportation or mobile outreach. So I know earlier there was a question of how do you get people engaged from the community? Sometimes we saw here at ETSS incentivizing people to come to places by giving gift cards helps a lot, or reimbursing them for gas, or giving them something else. So that helps a lot, just figuring out what the community needs when it comes to other social determinants of health and helping them meet those needs. And then what's available? So I wanted to quickly just go over some ETSS resources. So we have the Adult Services Department, we have a Youth Department, we have a Resettlement Department, and then we have a Grassroots Initiative. The Grassroots Initiative is one of our newest programs, and then the Adult Services works with adults mostly, and then the youth, we have youth sites, we have the Youth Summit, we have so many resources. I suggest when you have the time to check out our website and see all the great things we're doing at ETSS. And then here are some of the materials that we had on the kits. So as you can see, this is Adam 988 materials. We partnered with Adam H to do reverse translations. And you can find this, I think, just by going to 988 resources, and you should be able to find the translated ones. But this, we translated it for another grant, and then we decided to include this into the kits because we thought it would be very helpful for these communities because not a lot of mental health resources are translated in like for specific communities. And then all of our information for the social media posts, we mostly source from ready.gov. That's a great resource as well.